Hello, everyone. Welcome back. This is our 20th episode of Personalization Outbreak and our third episode on season 2. Our first 2 episodes this season discussed how personalization is changing and challenging the traditional norms in higher education and in corporations. Now, this week, we'll see its effects on healthcare. Our guest today is Dr. Neha Nanda, whom I refer to as the Paradigm Disruptor. You see, during my many conversations with Neha, I learned that she enjoys solving problems that allows her to be creative and question paradigms, something that we should all be doing today. Now, Dr. Nanda serves as the medical epidemiologist for Keck Medicine at the University of Southern California, where she leads the preparation and response to emerging infectious diseases. So you could imagine what she's been through since this outbreak started. Now, throughout the COVID-19 pandemic, Dr. Nanda has led protocol and guideline development for patient and healthcare workers' safety. She's an active member of the University of Southern California's Policy Committee for COVID-19, where she has served as an advisor for reopening plans for the different schools across the university. Now, today, we'll talk about the importance of co-designing the future of healthcare with patients and how to find the right balance between personalization and standardization on a systemic level. Let's get started. You are listening to Personalization Outbreak, a podcast about the collapse of traditional corporate standards in today's more personalized world. I'm Glenn Yopes. I'm a leadership strategist, author, contributor to Forbes, and founder of the Leadership in the Age of Personalization movement. On this show, I'm interviewing executives across multiple sectors to find out how the balance between standardization and personalization can exist. So, Neha, first of all, thanks for joining us today.
Thank you, Glenn. My pleasure.
So, Neha, I know that you are passionate and extraordinarily genuine about the care of those patients that you serve. But COVID has brought another level of intimacy in the work that you do that has really changed the paradigm for what patient centricity really means. Give us some perspective of what you've been through, what the research is telling us, particularly maybe around the African American and Hispanic populations. But what does patient centricity mean? It seems to me that for so many years we've been saying that we're patient centered, but we're really not.
Glenn, actually, that's a question that's so timely, given all the scientific data that is becoming available almost by the day. We get new data. And one thing that is also available in the popular media, we know that COVID really showed us our weaknesses as it relates to the potential gaps that we have when we are trying to be inclusive. And that very nicely ties into what we've talked about, the balance between standardization and personalization of care. And where is the right balance so we can actually conquer the structural racism that exists in the society. And with that, talking about patient centricity, what has been very, very important for clinicians and for people like myself, we are clinicians and we are responsible for system changes, is inclusion. And if you think about it at a patient level, as a patient, I want to be a part of decision-making. I want to have a shared decision-making. And the onus lies on my provider to have the cultural maturity to understand where I'm coming from, even though we hail from different backgrounds. And I think the reason why this is so important, and as you see in COVID now, we know that about the Black population is about 3 times at higher risk for hospitalization, 4 times higher risk of mortality compared to the other groups. And you know what? This is not something that we've only seen with COVID. Even if you look at the past, the number of the percentage of actually mothers who have suffered pregnancy-related complications is about 3 times higher in Blacks compared to whites. Talk about infant mortality. That's also higher in this group. So the point being that this is an opportune time for us to become inclusive in our interactions, which will obviously impact the outcome.
As always, Neha, you get my head spinning. So let me go back a minute, because I'd be curious about your perspective on the following. When we talk about finding balance between standardization and personalization, when we talk about the delivery of care to a patient, where the patient wants to be involved in shared decision-making, I'd be curious to know, how would you define balance? Because I think that what we're all trying to find in this pandemic, and as we move, to herd immunity and getting back to some semblance of normality, that we can't go back to bad habits, and taking action on the things that surprised us during the pandemic and finding that balance. What does that mean to you?
Yeah, so I think it's simply put, let's standardize the processes that are involved in getting the patient to the caregiver. Simply put, you can imagine scheduling, waiting time. And when we are with the person at that time, let's talk about individualizing our care to the patient. And this could be as simple as, okay, let's take a perfect example. When someone has been exposed to someone with COVID, we tell them, you need to self-isolate at home, right? For 10 days till you're asymptomatic. Very easy as a physician for me or a caregiver to tell the patient that. But what's personalization is asking him, are you really able to do that? Right? You'll see majority of the households in our community are unable to do that. That's where we put actions. We turn our words into actions by, let's create a setup so that you can actually self-isolate. Majority of the people have a room, let alone telling them to use a separate restroom, which is even more important if you want to prevent transmission. That's one example with COVID. Other things you can think of, first, if we just tell the patient, these are the medications you need to take, talk about hypertension, talk about anything, but then will you really do it? I need to create a system such that I can overcome the obstacles the patient or the person has in their daily life by help in setting up reminders, at noon, then at 6 p.m. That's what I I'm referring to as personalized care. And with the pandemic, isolating yourself is a perfect example. I could even talk more about therapeutics but I won't get into that. But that also requires a lot of personalization, because all the drugs that we have offered, except for one drug, remdesivir, all have some that we are using have received an emergency approval and have not received the formal blessing from FDA. So what that has required is a discussion with a patient every time, which is the way it should be when we are offering this drug to you.
So Neha, how have your perspectives changed based upon the way you interacted with patients last year to how you approach them this year? In other words, clearly personalization is where all this is going, but just as a physician that is dealing with other physicians that may have different views on how their interactions changed, how has that impacted your whole perspective around just being a physician and the criticality of that responsibility to that human? What changed for you?
Yeah, that's a very, very rich question. And I'll break it up with my interaction with my colleagues and interaction with patients and actually their family members.
Perfect.
Because remember, now in this pandemic, we are trying to keep family members not coming in to see the patients because of obvious reasons. So with my colleagues and peers, there is this sense of there's this sense of what should I say, that we have a common goal, because we all have been not in the know, we've been in the unknown. Every day brings us more light in the right direction and gets us closer to it. So there is this sense of we are in it together. Interestingly, a lot of our peers are from different ethnicities. There are varied cultural backgrounds and educational backgrounds. And I think with so much of effort going towards understanding different backgrounds, I think at a personal level, not only I, many of my peers sometimes find themselves making a proactive effort of trying to do that, which perhaps was in our subconscious in the past, which can only be better if you think about it.
Of course.
And also with my colleagues, I should also say trainees. For whatever reason in the academic world, it's believed that people with similar demographics tend to come together. That is, someone who has the same ethnicity is likely to mentor someone with a similar ethnicity or a cultural or educational background. Simply being aware of that is good, because that'll only make us a better citizen. So that's with peers and colleagues and trainees. With patients, with knowing that some communities have been underrepresented. Sometimes it's very helpful to share with the patient and acknowledge that we know in the past this is what has happened. And you'd be surprised how your relationship changes with the patient. I've never done that in the past.
Wow, that's powerful.
Because, it's not only COVID, even with H1N1 or with polio, go back. And if we look at our roots, this is something that has manifested again and again. So having that conversation brings a sense of openness in your interaction. And that helps break a lot of barriers that sometimes one experiences in the role of a physician and what the patient feels in his or her role. The last group is their relatives, their loved ones.
Okay.
I think, again, what you share with the patients, making sure they're on the same page as the patients is very helpful. And acknowledging the fact that they can't be with their loved one, even in the last minutes, is something that emotionally is a roller coaster, not only for them, but for us also. And just being in it with them makes your bond stronger. I say this because after we've cared for patients who have been discharged from the hospital, whether the outcome was ideal or not so ideal, having some kind of communication with the patients even after that tells you that you created a bond, and an emotional one, not just a caregiver and a patient bond.
First of all, Neha, I didn't expect to ask you that question, but I appreciate you answering it. I think it's led me to the follow-up question, and so you answered it beautifully. And I think our listeners and viewers are really going to appreciate that, because that's something that they didn't expect historically from their physician or caregivers. But so, what do you think stood in the way of moving in that type of a direction that COVID forced us to in the past? What stood in the way, and what are we going to make sure that we do as physicians, that you do as physicians, and your colleagues do to make sure that we don't go to bad habits?
Yeah, I think so. Why did we not do this as proactively as we are doing it now? I think has to do with a constant awareness that perhaps wasn't there all the time. Mm-hmm. And disciplining ourselves, disciplining is not the right word, but that's what's coming to my mind. Disciplining myself to always have that self-awareness is, we are only going to learn by practice. Practice makes perfect. I think it's just the proportion of the morbidity and the mortality that we are faced with the pandemic that has led us to think this way. And now that we've reached here, how can we make sure we continue to sustain the gains that we have had up until now? I think it's going to be, it's at an individual level. We can try and do our best at an individual level, but then you got to take it at a system level.
Right.
And that's where you talk about things that we've talked about in the past. Constant training with perhaps an avatar of yourself who has a different skin color, right? Multisensory tactics that make you comfortable interacting with groups that may not be demographically similar to you. In addition, talk about it at a organizational level. It's not news anymore that socially vulnerable areas at a higher risk of disease. You know, the simple number is, just last week we learned 1%, as the vulnerability index increases by a point, there's a 13% increase in incidence of COVID. That's the number of new cases in a community, and 14% increase in risk of death. Wow. With every 1 point increase. I say this because I'm getting out of the realm of individual. I'm moving into a system or a healthcare organization, and I'm trying to get the community into the picture. Okay. So our organizations have to be geared moving forward to be more inclusive. And either you tie it to a metric, or if you now look at what's the return on investment when you go to the boardroom? What's the return on investment? And there is a return on investment because we know firms that are, or groups that are more inclusive with, I think it was, the number was 10% increase in gender diversity. Mm-hmm. They see an increase in their earnings before taxes and income to about 3%, or it was less than 1%. Yeah. I think stronger correlation has been noted in UK. So I think moving forward, it's not only at an individual level, but it's at a system level that we have to try and get to our true north.
So, Neha, before we shift, because I like to talk about inclusion as a growth strategy here, Scott, what are you thinking?
Well, maybe just at least one, but maybe two quick observations. One, I really am loving in terms of this the way that you're speaking about inclusivity is. You're bringing layers to that I don't think we often talk about when we talk about inclusivity that I think are important, and especially what you just mentioned, Neha, when you were talking about you went from the individual to the org, right, to the bigger group. And what I think it might be an important lesson for us to pick up on, Glenn, from what Neha's saying is, I think the way I would characterize what Neha's inclusivity concept, her domain, right, the one where she thinks inclusivity, what's going on, it's an ecosystem. Right? It's all about ecosystem. She's not looking at an ROI in a simple economic term, right? She's looking at the entire ecosystem that feeds into that ROI. And for example, Neha, when you started talking about patient centricity, right? The very first thing you did was you talked about people that weren't the patient, right? But the patient was right in there too. And so that's what I'm saying. I think it's easy to just say, oh yeah, of course you should talk to the relatives. Of course you should talk to the colleagues and others. But no, I think this is an important point we have to underline, because what she's doing with inclusivity is she's helping to point us not towards the exact people in the room at the moment in the process, right? But actually looking beyond it to the entire ecosystem that requires and benefits from that process, but also can be damaged severely because of how we run that process. So I appreciate that. And I'll save my second part for the end. But Neha, I'm loving your ecosystem approach towards inclusivity.
Thank you, Scott.
Right on. No, you're making me think about inclusivity in a different way by thinking of it as an ecosystem, something that the interdependence of it. It brings interdependence into inclusivity in a way that I really haven't heard a lot of other people talk about it.
Did you want to comment on that, Neha, or no?
I like where Scott is going, the way he's kind of called it an ecosystem, which takes me to think about, Glenn, I don't know what you have in store.
No, go. Just go. This is the beauty of this conversation. It can flow. Keep going.
Okay, perfect. So, when you talk about disrupting an ecosystem so we can reach our true north, I think it's very imperative for us to know, why did we reach here? Yes, inclusion is something we know we haven't been very, very conscious of. Let's put it that way. But why? So to me, it sounds almost like if you look at our history, you look at the huge trial that was done in Alabama, where we enrolled patients who had syphilis, about 600 of them, and they were not offered treatment. Even when treatment was available, it was from 1930 to 1970. I think it was 40 years. And we did not offer treatment to the people who actually had syphilis because they were part of a trial. And majority of them were Blacks. That tells you that, see, our history is also something that has fostered lack of inclusivity, and we need to debunk those processes that facilitated that. I'll stop there, but I just wanted to kind of remark on one instance of what our history has done, and we shouldn't let history repeat itself, and need to be sensitive of the processes that facilitated that in the past.
Well, the reality is that systems and protocols have historically been very exclusive because the goal in the mission was to do the things that we were most comfortable with, that, and I'm talking about across all sectors, that can make us make money and can drive outcomes that we felt comfortable driving. But now we live in a new world. And if I were to ask people, which I have, what inclusion means, you would be amazed at some of the responses that I've received. But the fundamental one that I've never received is that inclusion is a growth strategy. In other words, the broader and more interconnected our perspectives, the more confidently we can co-design the future together. And that's fundamentally what's been missing. We've never really co-designed the future together. And people can continue to use the excuse of regulations. We learned that COVID exposed that excuse. But it's fundamentally, have we had the right conversations to propel the right actions? And so with that, Neha, how would you as a physician define what inclusion means? Like, what does it mean to you?
Inclusion as a physician, if I only wear that hat, simply to me is irrespective of the background of my patient, whether it's educational, cultural, ethnic, all backgrounds, I and the patient are actively making decisions for us.
Beautiful. See, I can tell you wow. And Neha, that is a powerful response, because what you just said is you've shifted the balance of power to the individual. And yet we're still having a narrative. And by the way, I want to make sure that our listeners and viewers know that it's an important narrative, but we're still talking about belonging. And you already have gone to the power of decision making. You see, my point is that I think sometimes when we have these discussions around inclusion, that we're still at the narrative around permission rather than action, which then oftentimes takes it from away from strategy and implementation to an initiative that may come and go. So what stands in the way of healthcare providers being more inclusive? And what are actions that we should be considering now? Because let's face it, we've witnessed the urgency with the pandemic, but I think when it comes to the Black and Hispanic and other diverse populations, but particularly the Black and Hispanic populations, we're so susceptible to chronic disease states. Can't we take what we've learned from COVID and begin applying preventative measures right now to how we view the risks involved with chronic diseases? I threw a lot out there for you to process. Take your time.
I think if we had to, what can we do now to conquer what we have been struggling with? Is today, and I'm going to first talk about COVID.
Please.
You have a vaccine out there today. That is relatively safe. I don't say it's 100% safe, because in medicine, you never say anything is 100%. That's life. And today, we know that about 60% of the whites of our white patients or population is willing to accept the vaccine. If you look at it as a nation, at a country level. Mm-hmm. With Blacks, it's 40%, 20% difference. Mm. Today, what I can do now is start having a conversation about vaccine hesitancy with my patients, which is only going to help us. Because we know vaccine is going to prevent so many things. It'll help us reach a state of, like you said, semi-normalcy, or a new normal. And it will break so many invisible barriers that I may have had between the patient and I. Mm-hmm. Because my conversation is going to start with acknowledging what our history has taught us and what the big gap COVID has shown us between different communities. And hey, let's be partners, right? The patient and I, to narrow the gap or to dissolve the gap. That's the first thing that comes to my mind that we can do now.
And so, okay, that's a great one. How do we build partnership with the patient? That's a whole other conversation, but I love it. How do we approach, how do we take the learnings from COVID and rethink protocols for Black and Hispanic communities as it relates to their susceptibility to chronic disease states and how they can be more preventive?
Yeah, so I think we've talked about making a change at an individual level. And I think we are pivoting now, transitioning, I should say, yeah, to how we can make a change as a system. And that, our true north is that it gets hardwired in the culture. for us to reach that, I think at this time, it may be tying into the metrics. Can we get to doing mammograms? Say 80% of the females above the age of 50, above the age of 40, should get their mammogram in this pocket of LA County.
Yep.
And if you do it, there is some reward, figure out a way to incentivize. That's how I think one can get to the community at large, by talking about preventive medicine or colonoscopies or influenza vaccination, if you talk about infectious diseases. Yeah.
So Neha, it's interesting that one of the first questions I asked you was, what does balance mean to you? And I have felt, during our time today that you've defined it already, that balance begins with the individual, and then it moves to the system, right? Because we could always, in other words, balance in today's age of personalization must begin with the individual. And from what I've heard from you, I feel that while you personally, professionally, you as an individual see that need, and it's so crystal clear that it begins there, are there still barriers that make it difficult for physicians and caregivers to see the need to get to know and become more intimately connected to that individual? I mean, I think it's simple. It seems to me that we can have a couple, several interactions and feel like we figured it out, but sometimes it takes much more than that. And sometimes the training doesn't give us enough to move it from individual to system. Do you see where I'm going with this? And if you can disagree, I'm just wanting to get your perspective.
Yeah. So I think when you touched on how our education system can also include things about inclusion. It can be done very simply at the time of recruiting our residents or our fellows, right?
Yeah.
This is something as an organization or as a program, if we prioritize, that's the kind of individual you can hope to recruit.
Yes.
Then to try and balance between individual and system, perhaps showcase to the individual the characteristics of the individual patient that are demographic. This person, the address of the patient is always there.
Yeah.
On the electronic chart. And the ethnicity is also always there. But I have to click on the medical record a couple of times before I get to that. You can imagine, right? A patient healthcare record, I got to go to the demographics and then I get to the address.
Yeah.
So maybe things like this can be a little more visible. And if I knew this person is coming from an area which is very vulnerable, my care for the patient is going to be exactly the same for a person who comes from a very elite area. However, perhaps I'll make an effort to have a conversation about his community to get a sense of hesitancy around preventive medicine or, so many other things. Because at the end of it, after he or she leaves me after my encounter, he is going to be the messenger back to his community.
Exactly.
So I'm trying to think of a way how at an individual level, you can still bridge the process level systems and the individual can leverage off that. And obviously the system will. And that's really creating a new ecosystem, as Scott mentioned.
So when I say the system, I'm going to share a statement with you, and then I'd like for you to react to it. the cultural demographic shift has reached its tipping point. How do you react to that?
I think it had reached a tipping point a while back. It has now been showcased that it's reached the tipping point.
How about this? Metrics and methods to engage increasingly diverse patients.
I like that.
How do you respond to that statement?
I think when you say metrics and methods, it allows me to think of the stakeholder involved. Could be an individual and could be a health system, or any community system, any system, a health system, an organization. I think that would be a tactic to overcome the lack of cultural diversity that we have yet to experience.
I'll ask you this final question, and then I'd like Scott to provide some perspective. But how do we get inclusion to go beyond compliance to something that becomes part of our DNA in a healthcare system? Neha?
So a simple answer is we are looking for a cultural shift. So we don't have to succumb. For the regulators, if I say succumb to regulations, it's not smart on my part to say that. But for the audience and for you, where I'm coming from is regulation should be something that allows us to reach the bare minimum standard. That's where I'm coming from. But to go over and above what the basic requirement is, it requires cultural hardwiring, which takes time. We all know that.
I think that's what we're going through as a nation right now.
Yes.
The complete cultural rewiring. Neha, I can't thank you enough for your time today. I know these questions are not easy, but I could always rely on you and ask to address the issues that people are thinking about, but do not dare to talk about. And I think you've inspired, certainly you've inspired me. I'm sure you've inspired Scott, and you've inspired our audience. And I can't thank you enough for tackling these issues, because they're not easy. But that's why we need each other more than ever before. Scott, any final commentary?
Yeah, first I have to give my shout out to my new inclusivity ecosystem guru. My gosh, oh my gosh, that really helped me out a lot, the way that you were defining and operationalizing inclusivity. And I think that's something that's a thread, Glenn, that you and I have to think about deeper and carry over into a lot of conversations. But one of the things that your approach, Neha, has given me, or at least an observation that's kind of emerged, is essentially why inclusivity is so elusive for so many. And it's the irony of inclusivity, and that there's no such thing as the individual. That's what you were saying. And you said it in about 15 different ways, and in brilliant ways. Because, when you talked about peace and centricity, you talked about the patient, but the patient is an individual. So you started there, but it can't end there. That's not inclusivity, because there is no such thing as an individual. That individual that you're talking to is a collection of other individuals whose lives are interdependent upon each other. So what I really love is that you are helping us to see that inclusivity, I don't know that maybe it does start with the individual, but I don't know if it does. I think what you're saying is inclusivity is rooted in the individual, right? But it's not contained in it, because what you do with your inclusivity is you go forward and backward in space and time, which is brilliant, right? That's my whole approach to anthropology in general. When you need to connect with somebody and create that interconnectedness with a patient or a family, what you said is, I need to go back to history. And I find that same observation true when we talk about the history of humankind, that the more I stay in today and tomorrow, the more I see difference. The further back I go, say 7 million years, the more I see nothing but similarity, right? And so you go back into history to reclaim that moment between you and the patient and the patient's ecosystem. And I really love that. But the other thing that I'm grateful for is how you're also thinking about this in terms of the future, what inclusivity becomes, right? And so if inclusivity is rooted in the individual, but is contained in the past and the present, right, and the future, what you're helping us to see is something that I would have never put on the page. And that is, in order to get there, in order to do this better, we need process. I'm a process killer. I like to throw process out the window and reinvent. But what you're doing is you're helping us remember process is very important, and we control process. And if we can control it, maybe we can do something better as opposed to something worse. So just want to say thank you very much for reminding me the importance of process. And what I think you're saying underneath all this that is really happy from an anthropological point of view is that qualitative analysis, qualitative metrics have never been more necessary. But as you and I know, the reason we use quantitative metrics is because they're easier. But anyway, thank you, my ecosystem teacher.
Neha, thank you, Scott. Neha, any final comments?
Glenn and Scott, I love the way, Scott, how you ended by saying that we need to transition from a quantitative, I shouldn't say transition, there has to be a balance between a qualitative and a quantitative aspect to every venture we take after this pandemic. I love it.
We're going to need your help to do that because very few people do it the way you do. And the way you talk about it, I think, won't scare people who are a little bit afraid of the qualitative complexity.
Very good. Well, Scott, thank you. Neha, thank you. And as we always end the show, when you lead in the age of personalization, you will see things that others don't, do what others won't, and keep pushing when prudence says quit. Thank you, Neha. We greatly appreciated your time today.
Thank you.
Thanks for listening to Personalization Outbreak. Make sure to subscribe so you never miss a show. If you enjoyed the content, visit ageofpersonalization.com to check out our free streaming video series and learn how to get involved in the movement. I'm Glenn Yopes. I wish you a good day, and remember, without strategy, change is merely substitution, not evolution.